they try to take the x-rays, when they reset my foot,
Yeah.
it hurts.
It hurts. It hurts, right? But we need to move you, right? Because we need to somehow prop.
No, they were trying to
Extremity.
move my foot.
Oh, they were forcing movement on your foot? Oh.
So I was like, please don't.
Where did you get this done?
In Texas.
Oh, okay, then they're not Cypress students.
No.
Okay. Well, that makes sense. And you told them it hurts and they still kept on doing it?
Yeah, they were like, oh, try to do it as much as you can. I'm like,
Oh, they should know better than to force it.
like,
So they were forcing flexion.
yes.
Did you piss them off?
Huh?
Did you make them mad?
I don't have morphine in my system.
Okay. Yeah, so as Cass was saying, so pay attention to your patients, okay? Listen to them. Ask them to see how much they can do, okay, without hurting them. Assist them, but don't force them. Good point. Very good point. Okay. All right. But you're also going to need to move the extremity as best as you can to make sure that it's all included on the image receptor. But again, be careful and be mindful.
Oh, I have a question.
Yes. Back here?
Yes,
Uh-huh.
this one. So 2 projections.
Uh-huh.
So the oblique don't.
No, a minimum of 2.
Yes.
If you can get 3, then great.
Okay.
Okay, but rule of thumb is at least 2. Okay, not 1, 2. Now there are some exceptions due to patient's condition, or maybe because, like, for example, if they're on a backboard and you're doing a C-spine or a lumbar spine, and they're on a backboard or they're on braces and a straight AP, you're going to hit some kind of metal. Okay, even in a true lateral, you may hit some metal. Okay, that's where there is an exception where you can do one view, but you have to write that on the requisition. Okay, you got to let the doctors know that this isn't a true AP, this isn't a true PA, or it's not a true lateral. That you had to deviate or change your angulation a little bit to acquire the images, but you got to put that on the requisition. Okay, because they're going to say, why does my image look all distorted? Okay, with all these different angulations, whether it's your X-ray tube or there's an angulation on your image receptor, it's going to cause shape distortion. And you need to explain to the doctor why you are producing a shape distorted image. It's because of your limited, movement of the patient and using different angles. Okay, so you have to explain that on your requisition. Okay, that's part of what you need to do. It's important that you put that on your requisition. Okay, so but again, 2. Okay, so 2 projections, 90 degrees from each other. So barriers to a true AP. So this is what we were talking about earlier. So if they're on splints, if they're traction bars, if they're things that are metallic, that'll show up on a radiograph, you may not be able to go straight on or straight AP or straight lateral. So you may have to tweak your angle just a little bit. Okay, but even with that said, you still want to get at least 2 90-degree projections from each other. Okay, do you guys have this on your slide?
No.
Because I just talked about it. Okay, so there may be some shape distortion, however, it is acceptable, but be sure to let your doctors know that you deviated from your normal practice. Okay. So here we have an example of someone who is doing a C-spine. Patient can't, they can't rotate in an oblique position. They can't turn their neck. So now our tube angle is going to be doing the angulation and not the patient. So we're going to go in with a 45-degree angulation. Okay. This is an example of how to do an oblique C-spine with a collar. Now, when you guys are using grids, I'll talk about, this is going to be a couple slides down, but I'll just talk about it now. So if you're using a grid, okay, remember your grids run the length this way, right? So you can angle this way or this way because you are maintaining the line, the grid line, right? So your tube ankle can go up and down to the length of the image receptor. You just can't go from side to side. Because if you're coming down an angle this way, you're going to hit the lead strips. So there is some angulation that is acceptable, okay? But you got to make sure that your angle of your tube matches the line of your grid. Does that make sense? So in this case of this patient right here, they're going to place the grid underneath the neck. First of all, why are we using a grid? Body parts what?
Thicker
Body
than 10.
parts greater than
Thicker
10
than
centimeters. So the neck is greater than 10 centimeters, right? So if the grid was placed this way and the lines are going this way, are they going to get cut off?
Yes.
Yes. So you got to place the grid so that they are positioned this way. Now you won't get grid cut off. What's grid cut off?
Well, the image won't be projected on the
Yeah,
image
so it's the
receptor.
visual, it's the radiographic visualization. Oh, no.
It absorbs the.
So
Looks like lines.
grid cutoff, yeah, grid cutoff is that it absorbs the primary beam, not just not just the scatter radiation, but it's also absorbing the primary beam. So that's cutoff, and you have a change in density across your image, a decrease of the density. Okay. What are grid lines?
lead strips.
Okay. So grid lines then is the radiographic demonstration of the lead strips. So let me just ask you guys this real quick. If you were doing a portable study like this with a grid, which would be better? Which would be better in producing a higher contrast image, a high grid ratio or a low grid ratio? Which will produce better contrast? High grid ratio. Why? Because it absorbs more scatter, right? Scatter produces fog, which is increased density, right? So a higher grid ratio will clean up scatter much better, eliminating or reducing that fog, giving you a higher contrast and a more detailed image. It's coming back? Is it coming back?
Yes.
Okay. But what's the problem with higher grid ratios?
Increase technical factors. Increase mass.
Okay, not only do you have to increase your technical factors, but positioning of your tube, positioning of your image receptor, you have to be a little bit more precise. There's no room for error. There's no room for error. So, when performing trauma radiography, do you want a higher grid ratio or do you want a lower grid ratio? You want a lower grid ratio because there's more room for error. Your tube and your image receptor doesn't have to be completely parallel. There may be some slight angulation in there and you're not going to get any cutoff. There's more room for mistake. Looks like some of you guys forgot.
We're just being humble.
Being humble, accepting that you forgot.
No, not telling the answer.
Okay, principle number 2. When dealing with long bones, you need to include both joints, right? Yes? Okay. Here's an exception. So after your initial shot, your pre-shot, and now they want a post-shot after they've reduced it or after they've fixed the fracture, whatever, okay? Then you're going to want a post-shot. You did your pre, you need to include both joints, okay? Your post-shot, you don't have to include both joints, you just include the joint near the area of interest. So if the injury was down here to the ankle, I don't need the entire tib fib anymore. I'm just going to take an ankle shot for my post. Okay? Your initial, you need both. For your post, okay, close to the injury of interest. Okay, so that's principle number 2 for trauma radiography. Does that make sense, guys? So you don't need to take the entire extremity. Just focus on the area of interest for your post follow-up studies. When using a horizontal beam, we've talked about this over and over and over again. Why is it that we have to prop up the body or the anatomy?
Beam
It's
divergence.
because of the beam's divergence. Okay? It's because of the beam's divergence. So you need to prop up the body part due to the beam's divergence. Your body part is not projected off the image receptor. Alright? And again, I think you guys should know this by now. Look at the shadow to make sure that the body part is included in the image receptor. Alright. So grid considerations, again, you need to be properly centered. If you're going to use any type of angle, you want to angle along the length of the lead strips, not against it. Otherwise, you get good cutoff. So, what does it mean focal range?
SID,
Okay, SID, what does that mean?
source to image
Source to image
distance.
distance. So what about SID? What's your focal range?
Whatever one is needed.
Okay, so the grid that you're going to use, okay, there are labels on your grid. Look at the label. It'll tell you what your
SID.
manufactured SID is. Most grids are 40-inch SID. Okay. Now, if you're not able to get your 40 inches, table's too high. Okay, your tube can only go so high, but the table is so high. You're in the operating room. Doctors like to have their table way up here, but your tube only goes this high. Are you 40 inches? No, you're not. If you're walking in a small, if you're working in a small room, you may not be able to get 40 inches. So what the focal range then is, if you can't do 40 inches, look at your grid. It'll give you a focal range. Your focal range is this. It's your margin of error. If you can't get 40 inches, for example, your focal range, it'll say on that label, will say between 34 to 44 inches, which means that as long as you're between 34 to 44 inch SID, you're going to be fine. You won't get any cutoff. But anything beyond that value or below that value, there's a possibility you will get grid cutoff. Okay, so that's your focal range. It's your margin of error, or margin of forgiveness, if you want to call it that. Does that make sense? Okay. And some grids are completely flat. We've had grids that have a cap or an edge to it that fits nicely over the image receptor. But there are some grids that's completely flat without a lip around them. So you got to make sure you're using the correct side. If it's upside down, not placed correctly over your image receptor, you can get grid cut off. Okay? So this just basically covers what we just talked about. So the lead strips runs the length of the grid. You can angle this way, but I can't angle this way. Okay, here's your forgiveness. If I'm not perfectly straight, I can have a slight angle either way, as long as it's within, it says here example of 3-degree angulation. You get a larger margin of error with lower grid ratios. With higher grid ratios, you may not have that angulation or that forgiveness coming in this way. Okay? Okay. CR centering to near center line, so you want to be as close to the middle as, and it's hard to do that, especially when you are working with traumatic patients. Have you guys already done a portable abdomen with a grid? Okay, you put the grid with the image receptor underneath the patient. Now you've got your X-ray tube up there. How do you know if you're directly on top of it? How do you know if you're directly centered? That's where your challenge is, right? And it comes with practice. It comes, you become seasoned after a couple of years. You can put the grid underneath them with the image receptor, and you know exactly how to line up, but it comes with practice. But as you're first doing this, it's hard to see where that grid is placed. You're taking your x-ray, you develop it, and in your case, it's not gonna look like, it's gonna look modeled, okay? Because of the lack of absorption, the lack of x-rays reaching the image receptor, because your grid is absorbing everything due to your misalignment. Okay? And if it becomes too modeled because of your lack of position or poor positioning, they're gonna have to repeat that procedure. Okay? All right, do we have any questions? Grid cutoff, right? Down there in the bottom. Are we gonna get grid cutoff with digital imaging? I just said you don't, right? What do you get? You get model. Okay, types of portable machines. Types of portable machines. Portable X-ray units. There are 3 types. And they're classified by their batteries or their stored energy. Before I was going to lecture on this, I wanted to make sure that the information up here is current. And apparently, you still have this in your book, so I'm going to talk about it. Because I looked at this, I'm like, what the hell is this? I know, right? Has anybody seen that before? I've never seen anything like that. Yeah. So battery powered. So type 1 is battery powered. They're technically acid type of batteries, usually about 12 of them in connection. So 10 to 16 rechargeable batteries. Okay, batteries generally contain chemicals. They're not as strong, they're not as accurate in the power output as the capacitor type. Again, limited in power. Also, speed goes 2.5 to 3 miles per hour. The maximum incline, if you're going up a grade in the hallway, you can't go more than 7 degrees. Okay. I wasn't going to lecture about this, but it's on your book, so there it is. Versus the standard capacitor. Capacitor stores electrical charges. Again, much more efficient than that of the battery version. And then you have the combo, battery and capacitor. Do you guys have machines that look like this at all? Any of them?
Yeah, ours look like the first one.
Yours looks like
Type
that?
number 1. I think.
Looks like that?
What do you say?
But the look, yeah, the look, yeah.
Yes.
Yeah, but not like that. There you go. Okay. C-arms, mobile C-arms. What does a C-arm do? Do they take still shots or do they take motion
Both.
dynamic images?
Both.
I heard both. Yes, they do both. Okay. But they're mainly used for what? Dynamic imaging, right? So, fluoroscopy unit. It is a fluoroscopy unit. It's a C-arm with an X-ray tube and image intensifiers, and also 2 monitors for viewing. It features digital imaging and storage, image hold, image enhancement and masking. So what that means is that you can manipulate the image. You can go from a positive to a negative. Okay, where some images bone looks white, and if you reverse it, bone looks black. We can also do that with vessels when we fill them up with contrast. The vessels appear white one way, and when we reverse the image, we can make them look black. We can subtract. Subtract means that you can remove some of the surrounding structure so that you're only focused in the area of interest. How many of you guys have done C-arms? How many of you guys have used some of these features?
For sure.
Not there yet, right? Okay, eventually you will. Especially when you're working with vasculature, that's where they use a lot of subtracting and masking. Masking is this. What they will do is they'll take an image of a body part, okay? Let's just say it's the leg. They'll take an image of the leg. They'll inject contrast, and you have vessels going in all different directions. Okay? Oh, one more. Okay? So they'll take an image like that where it's filled with contrast. Okay? Then what they will do is they will take this image and lay it over, it's kind of laid over the same leg, but they don't have to inject contrast again, so they can use that as a map to put in their wires and different stents without having to inject contrast, because we took in a previous image with contrast in it. So this just gets laid over the current study that they're doing. That's what mapping is. And I don't even know if I explained it correctly. You have to see it to understand it. Okay. Thing about the C-arm is that it has infinite positions. It's very fluid, very robotic. So you can obtain many angles, many projections. Here's an example of a horizontal projection for a lateral hip. This is going to be most common here in C-arms, is hip replacements. The challenge here is you're going from AP, okay, you do this AP, so here's your image intensifier, here's your X-ray tube. So you go to AP, okay, and then you go to a lateral. The challenge here is making sure that this X-ray tube and image intensifier doesn't hit the table, doesn't hit your doctors. The other challenge is making sure that you don't contaminate the sterile field. It comes again with practice. Okay. So it looks like they're setting up here, and if you've already been to surgery with one of your techs, what they do is they set up the equipment first before they drape the patient. So that way when the doctors do need you, you just come in and start operating the equipment. You've already positioned it, you're ahead of the game. Okay? You do that now, and you don't do it later while the patient is cut up and the surgeon and the surgical tech are setting everything up. This is something that you do before. Okay? All right. So these are the different features that the C-arm can provide. We have a mag mode. It just basically loads up the image. Pulse mode. I think we talked about that in radiobiology. Okay, this is where the energy is delivered in pulses. Is that bad or worse for the patient?
Good.
It's better for the patient because the energy is delivered in pulses. The images are visualized in pulses. So less X-rays, less exposure, but what is the downfall of using pulse mode? The image is not as good. Okay. So if the doctor wants a better image, you can always switch out of pulse mode. Okay. You can take snapshots. AEC. You guys learned about AEC with Ms. Smith yet? Yes or no?
Yes.
Yes. Okay, so AEC is automatic exposure control. So what AEC does is that it automatically keeps your image at a certain brightness. And no matter how you move your tube, it will change the brightness for you. But what is it that's being manipulated or being adjusted as the image is trying to maintain brightness? So let's just say I have my C-arm, right? And it's over my belly. Okay? And I moved it slightly over my L-spine now. Okay? Now, my L-spine is going to be a little bit thicker. Right? It's more dense.
So it's going to be more exposure.
Right? So when I go over my L-spine, my image is going to get suddenly dark. So the AEC kicks in and increases the mass. Mass is related to brightness on the screen. So it adjusts for the different composition, the density, the thickness of the different body parts. So depending on what area your x-ray tube is in, if it's in thinner parts, it's going to decrease the mass. If it's on thicker parts, it's going to increase the mass. In other words, what am I doing here? I'm decreasing my brightness or increasing my brightness. And that's what the AEC does. It compensates for the different body thicknesses and composition of the body part to maintain constant brightness. Okay? That's what it does. Okay? It's automatic. Now, can you bypass that and adjust your KV and mass on your own? Yes, you can. Okay, but mostly when you are in the surgery, we just leave it on AEC. Okay, foot pedaling for who's making the exposure? Who's making the fluoroscopic exposure? The doctor is. Can you? You can with the doctor supervising you. Okay, but it's usually the doctor who's stepping on the pedal. Now, does the doctor, the surgeon, do they need a fluoroscopic permit?
License.
I see a lot of this. We should not be performing a fluoroscopic procedure unless that doctor has a fluoroscopy permit. And if they don't, they shouldn't be doing it. Okay? Because now it's your ass in the line. Seriously. Okay? So, it's the responsibility of the managers in ORs, the responsibility of managers also in radiology to make sure that when you are going in there to do a fluoroscopic procedure, that the doctor is certified to perform fluoroscopy. Okay. I'm going to skip this. I don't do this anymore. Okay, so 3 cardinal rules. Okay, why is this such a big deal? Following the cardinal rules in an OR suite.
Is that a baby serum?
It's a baby serum. Yeah.
What?
It is. Yeah, it's called a baby serum.
Is it?
Well, we call it an orthopedic serum. Yeah. But baby serum is, yes, it's good. Yeah. That's a tiny serum. But why are we concerned about time, distance, shielding in OR? Do we have a barrier? Can we step out of the room? No, right? We are in an open environment, so you better be practicing distance. Okay? Distance, and make sure that you're shielded and minimize your time around the source. We don't have a barrier now to protect us. It's only our shielding. So key factors here is going to be distance and also shielding. Right? I'm going to get to that in just a little bit. We're almost done. Protecting the sterile environment. You're going to be in surgery. So there's got to be a barrier between your equipment and the patient. You don't want anything falling into an open, invasive area. So we keep everything clean. So before you enter the OR suite, what are you going to do with your C-arm equipment? You want to clean it up. Okay? Make sure it's nice and clean. That's your responsibility. What else is your responsibility as a tech when you are performing fluoroscopy or any type of portable X-ray procedure in a surgical suite? Who's responsible for making sure that everybody in the room is leaded?
Tech.
The tech is. Okay? So before the doctor steps on that fluoro pedal, before you go in there to shoot an X-ray, you're going to say, is everybody in the room leaded? Okay? Just ask, is everybody leaded? And they'll tell you whether or not they are protected. So you're responsible for maintaining a sterile environment. You're making sure that everybody in the room is leaded. Those are some of your responsibilities. Before you bring your X-ray equipment in, you want to clean it up. How do you enter a surgical suite? Can you go in your regular scrubs? What are you going to put on? Okay. Yeah. So you're going to change into their scrubs, or they also have what's known as bunny suits. So you can keep your scrubs on, but you're going to put on a bunny suit. It's a clean, disposable suit that you would wear. Minimum requirements in entering the surgical suite is a hat and a mask. Do you need shoe covers? Shoe covers are optional. what's most important is the mask and the hair cover. Because we're trying to maintain sterility, making sure that nothing falls in or nothing gets breathed in into an open wound. Okay? So we got different ways of maintaining a sterile area. You've got the draping. I think most of you guys are familiar with this, right?
Mhm.
This is how your techs do it. All right. So when placing the drape, you can touch any part of this with your bare hands. This is more of our concern that when we place the drape over the image intensifier, that we're not contaminating that part, because doctors will grab that image intensifier and move it where they want to. Okay, so we got to make sure that this is clean, sterile. Okay. Again, different types of cover to maintain sterility. I've only seen a few of this in my lifetime. Is a sterile shower curtain placed between the patient and the technologist. Okay, on one side you have the technologist. This is the non-sterile side. You have the shower curtain. On the other side is the sterile area. I've only seen a few of those. Okay. Another thing of importance. When you're in the room, when you're in the room during a fluoroscopy procedure, is this the type of lead aprons that you guys put on? Okay, it's just a front cover. Never ever turn your back on the x-ray equipment. Be conscious about that. It's the same thing that happens in fluoroscopy in the x-ray room. During fluoroscopy, if you're wearing this type of shield, always face the fluoroscopic unit. You never turn your back on it because you're not protected. It's only protecting the front. Okay? Okay, I think the last couple of slides are referring to the ISO exposure, the amount or the intensity of the exposure coming from the x-ray tube, depending on what part, whereabouts in the room that you are standing. So, in this position, okay, your C-arms generally sit up this way. Your x-ray tube's on the bottom, your image intensifier is on the top. Okay, so the x-ray tube on the bottom, it shoots x-rays upward. This is going to be the most safest position of the C-arm. Okay? Now for you as a technologist, where are you going to be? This is showing the doctor. So this is the amount of radiation the doctor's receiving. Because you as a technologist, are you going to be over here? Where are you going to be?
Opposite side.
You're going to be somewhere over here. Okay? Remember distance. Okay? And if you are standing this close, who are you going to use as your shield? The doctor. Okay? So most of the exposure comes directly from the x-ray tube. It's greater down here at the x-ray tube than it is at the receiving end. Okay? It's more intense here at the x-ray tube than it is at the receiving end, the image intensifier. And I'll show you guys over here. Okay? So again, it's stronger here at the x-ray end. It's less intense up here where the intensifier is. All right? So if you are going to do a horizontal projection, you don't want to be where the x-ray tube side is. You actually, and it sounds funny, but you want to be at the side where the x-ray is shooting towards you. Okay? That would be your image intensifier. So you want to be at the opposite side of the x-ray tube, is where it's less intense. If you have to be that close. Okay? So the most intense part of the x-ray comes from the x-ray tube, not the intensifying screen. So it's okay to be on the opposite side. So even though shooting this way, it's okay. You don't want to be over here. Okay, and this is the opposite. Now you have the x-ray tube on the top, image intensifier on the bottom. Again, this is probably the worst position that you can be in, is in this position. And I told doctors that too, because they want, see the thing is, they want the x-ray tube up here sometimes because it's smaller. They're able to work a little bit closer with the patient. The image intensifier is bulkier. Okay? So let's say put the x-ray tube on the top. I would go, So, well, why not? I said, because you're gonna blast your eyes, you're gonna blast your thyroid. You're gonna get a larger dose. Really? You're saying, really? I said, yeah, really. Well, they're saying the X-ray is going down this way. I know the X-ray is going that way, but there's a lot of scatter radiation that's coming from the tube that you're gonna be affected by. So sometimes you gotta educate the doctors. Yeah, they might scoff at you, but you can share some of your knowledge. All right, guys. So, before you go, next week you guys are meeting with Mr. Siegel. You guys see that on your syllabus? You have a meeting with Mr. Siegel next week. So I don't have class with you, but Mr. Siegel will be here. So what's going to happen in our next 162 meeting?
Talking about internship.
Between you and I. Your next 162 meeting is going to be with Mr. Siegel. Your next meeting with me is going to be what? Your final exam in 2 weeks. Okay? Instead of me doing a review, I'm going to upload the review. Okay, so I'm going to upload it. So that's what you're going to use to help you study it's a cumulative exam, okay? So your exam is in 2 weeks. I will upload the review sheet. Okay, and I think you will like it. Okay?
Thank you.
All right, guys.
Thanks.
So we're done for today. Who's attending the ceremony? Yay, okay, so I'm going to see you guys later on. Okay, what time is it? 4:30, right?
4:30.
Okay, try to stay within your group. You guys have family members coming?
Yeah.
Okay, so try to stay within your group. If you have families, it's okay to sit in different areas, but just try to stay within the same area. Okay? And listen for instructions.
Huh? Eddie? Huh? Eddie, yeah. And you, Mark? Mark? Mechanical? So, the class.
Yeah, I'm just saying to stay within the area. So that way when they come up on the names, you guys know. Except for us.